So in this talk today, we'll talk about acute deep venous thrombosis. That's the one that scares people a lot, obviously for good reason. I mean, acute deep venous thrombosis, you hear about it a lot. Um, you know, people getting off a long flight and keeling over because they have a blood clot in their leg that goes towards their uh, lungs, pulmonary embolism. By the way, there's a misperception that these clots end up in the lungs. They don't typically end up in the lungs. What they do, so think of this like a circuit, right? Legs, the veins return blood from the legs back up towards the heart. But once the clots pass into the heart, they usually flip out of the outflow channel of the heart, where they end up in the lungs, which is the filtering mechanism. Uh, and the gas exchange mechanism. So clots in the legs tend to flip through the heart and end up in the lungs, unless sometimes when patients have a hole in their heart, patent foramen ovale, which is a hole in the top part of the heart, or another defect like that, then sometimes these clots will flip through those holes and end up in the wrong side and cause strokes and other issues. So that's a little more uncommon. Pulmonary embolism is the typical sequelae of a clot breaking off from the legs and going towards the heart and lungs. So in terms of the diagnosis, so what's the typical presenting symptom of a DVT or acute DVT? Well, probably the most common thing I see is somebody comes in the office, they call and they say, look, my leg is swollen all of a sudden. That's what I counsel people. Like, if you wake up one day and your leg is really swollen out of proportion normal, be worried about that. I need to see you. So leg is swollen out of proportion normal, no really predisposing factor for it. Come in, get a venous Doppler done, and if it shows a DVT, then you get treated. Okay. So what do we look for in a venous Doppler? Well, we're looking for, so normally when we look with ultrasound Doppler, we're looking at the vein itself. We're looking for its compressibility. We want that vein to be nice and compressible. We don't want to see any, we'll call echoes in there, structures or abnormalities inside the vein. We don't want to see that. And we don't want to see that vein dilated at a particular location. So if we're looking at a vein, we're thinking about a DVT, we look at the vein, it's got echoes in it, densities in it that are abnormal, and the vein looks enlarged, we compress on it to make sure it's not an artifact. If it doesn't compress, shows these other structures, acute DVT, they need to be treated. So that's what we look for with Doppler. So most common reason I see DVTs, we'll call idiopathic. Somebody just shows up with a little swollen leg. But then there's other reasons people get DVTs. Like, for example, a classic example is you go through an orthopedic surgery, like joint replacement surgery. Now, the orthopedic surgeons are very good. They try and prevent this happening by giving you what we call prophylaxis, blood thinning medicine, or special compressive pumps when you're in surgery. They try and reduce the risk of that happening to you, but it still can happen. And so we have a direct channel with our orthopedists. If they're worried about a DVT when they see somebody post-op, they send it right to our office. We do the ultrasound, diagnose it. If they've got a DVT, then we treat them appropriately. So, after a certain procedure, orthopedic procedure, laparoscopic procedure, polytrauma, where you have, big traumatic injuries, spine surgery, any of these kind of things, vascular surgery even, there's a higher risk for DVT. Even though you use blood thinning medicine, it's still higher risk for DVT. So there's multiple things that can cause it. Nevertheless, the treatment is you need to have blood thinning for, depending on the inciting agent and your risk for clotting, 3 to 6 months. So first time somebody's diagnosed with a DVT, 3 to 6 months of blood thinning. Second time it's a year. Third time it's a lifetime. And so unless you have a clotting tendency, then you may need to be on it lifetime. So the most common reason is idiopathic. We don't know why somebody developed DVT, but then there's settings where you can develop it, from like trauma or previous surgeries or cancer predispose you to DVT. So there's different things that can do it. So if I see somebody, they have a predisposing risk factor, I'll have them see a hematologist or a blood clotting specialist to make sure, like a family history DVT, you have a mutation in your genetics that predisposes you to this stuff, then you need a genetic workup. And sometimes it doesn't run in your family. You're the primary, we'll call it locus of mutation. So it just happened to you, unfortunately, and you're at risk for DVT. The most common genetic risk factors, factor V Leiden, which tends to occur in Scandinavian populations, but I've seen it in Hispanics. So, you know, you need testing if we feel that you're at risk for recurrent DVT, because we'll treat you differently with this stuff. Nevertheless, you come in, we diagnose you with DVT. Years ago, we used to put people in the hospital for this stuff. We'd start you on blood thinning medicine, heparin, and then warfarin. We don't do that much anymore. The rationale was, you know, you're at high risk for it breaking off and go towards your heart and lungs. So we need to put you in the hospital, put you in bed rest for 5 days, put you on these medications to reduce that risk. Well, studies have shown that it's not necessary anymore. So if you're fairly good health, and then we just put you on blood thinning medicine. There's several ones that we use. I don't use warfarin much anymore. We used to put people on Lovenox shots and then convert them to warfarin. You don't want to just start warfarin, by the way, in and of itself, because that has a counterproductive effect sometimes. It makes you pro-clotting, so you need to be on Lovenox first and then warfarin. But I don't use warfarin much anymore. It's difficult to manage. You have to get your blood work done regularly. You know, this proton-with INR level, you have to check it regularly. You have to have the dose adjusted, and it interacts with certain medications like antibiotics, Cipro, any of these fluoxetins, ciprofloxacin, levofloxacin. All these things can interact with warfarin, so I tend not to use it much anymore. I use Aliquosin, Pradaxa, or Xarelto. And these are pretty simple to use. There's a loading dose and there's a standard dose. Like for example, Eliquis, the loading dose is 10 milligrams twice a day for 10 days. And then the standard dose is 5 milligrams twice daily for the duration of the treatment. With Xarelto, it's 15 milligrams twice a day for 3 weeks, and then 20 milligrams a day, standard dose for the duration of the treatment. So you come with DVT, I'll determine what your risk is, why this happened to you, or try to determine it, and then we'll start you on a treatment plan for it. These medications are generally safer than warfarin, but you still need to be careful with them. I mean, you know, you can't get into an MMA competition when you're on Xarelto. Makes sense, right? You can't take a, you know, header or blow to the head when you're on blood thinning medicine. You bleed into your head, that's a big deal. So, you know, my brother's a neurosurgeon. He'll tell you they don't like to operate on people who are on these blood thinning medicines. They're hard to reverse them. There are some reversal agents, by the way. So you have to be careful with this stuff. But nevertheless, the risk of major bleeding is very low. My mom was on Eliquis for another reason for years. She was 88 years old. And so it's actually fairly safe. You just have to be careful. Blood in your urine, blood in your bowel movements, we need to know about it. You're going to bruise more. Just count on it. You'll bruise more on these medicines because they're super strong blood thinners, but they're pretty safe. And the consequences of not treating a DVT is that this thing can break off and go towards your heart and lungs. By the way, these medications, the point of these medications is not to really dissolve the clot. What it does is stabilize the situation out, and then your body says, I got a bruise inside of me, and get rid of it. And so your body really does most of that dissolving work. These blood thinning medicines kind of reestablish the harmony. So blood always has a pro-clotting and anti-clotting component. When you clot, the pro-clotting component's won, so the anti-clotting component's lost, and that's why you tend to clot. So what these medicines do is kind of reestablish that harmony, so your body says, something's happening inside me, and get rid of it, and it'll dissolve over time. So that clot has 3 options, by the way. It can either dissolve completely and go away, or becomes chronic clot, like scar tissue, or it recanalizes, meaning it reforms a channel of flow through it, but the treatment's still the same. So that's the point of treatment for DVT, is to prevent this stuff breaking off and going towards the lungs and causing the pulmonary embolism. Now, we'll discuss pulmonary embolism at another date because that's a topic in and of itself. And then we'll also discuss chronic DVTs at a later date. And I think we should discuss superficial phlebitis, which is a different problem handled differently than acute DVT. There's a lot of confusion about superficial phlebitis or phlebitis versus a DVT, where it needs to be treated or not. Couple of little other additional things about DVT. A calf vein clot is technically a DVT, but it does not necessarily need to have the strong blood thinning medication used for it. I personally get a little nervous when I see a extensive calf vein clot. I may elect to put somebody on a short course of blood thinning medicine. Number one, it helps them recover quicker. Number two, to prevent it extending into the popliteal vein. The popliteal vein is that deep vein behind the knee. If it gets into the popliteal vein, the risk for it going upstream is a lot higher. So I kind of try and use a little bit of common sense or my own judgment on whether to treat calf vein DVTs with blood thinning medicine. If it's a small localized area down the mid lower calf, I'm not necessarily going to start somebody on blood thinning medicine, but I will counsel them. Look, if this stuff, if you swell more, have more pain, I need to know, because I'll bring you back in and I'll duplex you. And most of the time when people call and say they have more pain and swelling, we'll reduplex them and find that they don't have extension of the problem. But it's far better to not miss out on these things if you can treat them conservatively. So anything essentially from the popliteal vein up or an extensive calf vein clot, I'll treat with blood thinning medicine. Again, the reason to prevent it progressing, breaking off and go towards your heart and lungs. Okay. But anyway, I'll talk about pulmonary embolism and phlebitis, superficial phlebitis, which is a different entity and treated differently. Oh, one more thing. In the old days, we used to call the deep femoral vein, we used to call it the superficial femoral vein. Why, I don't know. That caused a lot of confusion. We don't call it the superficial femoral vein because it is a deep vein. And the reason I think is because the veins are named kind of similar to the arteries. So the arteries, the superficial femoral artery is the blood vessel that brings blood from the groin crease down towards your lower leg. And there's a femoral vein that goes with it that brings the flow back up again. And so that vein kind of was named after the femoral artery, superficial femoral vein, but it's a deep vein structure. So that nomenclature of superficial femoral vein is really not used anymore. It's a femoral vein. It is a deep vein, and that needs to be treated with blood thinning medicine. Again, questions, please go ahead and ask questions if you want. Again, I can't get into your specific situation because of the medical legal issues, but my hope is to provide you with some kind of level of comfort and expertise, so these questions that you might have will at least help you with some guidance in terms of what's happening with you, if you haven't gotten good answers from whoever you've been seeing. Thank you.